Dear colleagues, good evening. I would like to thank the organizing committee for inviting me once again in this meeting. So in the next few minutes, I'm going to present to you an interesting case of a relatively young patient. So we have a 61-year-old male, quite obese, with 46 BMI. He presented at the emergency department with acute respiratory failure and hypoxemia. He had a history of MV prolapse, but he didn't follow up. He didn't go to any cardiologist. And he had a history of arterial hypertension. This was the chest X-ray on admission. His CRP was 7, BMP of 500, and increased white blood cell count. I need to mention that all cultures on admission and during his in-hospital stay were all negative. So this was his chest CT on admission. You can appreciate the bilateral pleural infiltrations, the bilateral pleural infusions, and the pulmonary infiltrations. So the radiologist said that there's definitely the infection on the top of acute pulmonary edema. So this was the transthoracic echo. So you can see a torrential mitral regurgitation due to the flail of the posterior leaflet of the mitral valve, and the coaptation gap around 30 millimeters, which is quite big. The LV was mildly dilated with good contractility, as well as the LA, which was, again, mildly dilated. And this made us think that probably the whole condition was acute or subacute. So what we have a 61-year-old male, obese, with acute respiratory failure, pulmonary infiltrates, and a picture of probably RDS in his chest CT, severe mitral regurgitation due to posterior leaflet flail, good LV function, pulmonary hypertension. The patient was starting high-flow oxygen, IV diuretics, empirical antibiotic treatment, and steroids, So this was his chest CT on the 6th day. You can see that there's definitely no improvement. There was no clinical improvement as well. And on the 8th day, because of hemoptysis, he had a CTPA. There was no emboli, but you can see how tragic his lungs are. So we had all this. We had a patient that didn't went well, despite what we did. We had to make a decision. So the heart team discussed, and there were two options, either the surgical MV repair or replacement, or the transcatheter edge-to-edge repair. So this was the transthoracic echo of the patient. So you can see the flail of the posterior leaflet with the ruptured cords, the regurgitation, more views of the mitral valve and the P2 prolapse. And basically, the posterior leaflet had no support. There were ruptured at least 3 cords, so it was unsupported. The planimeter showed an MV area of almost 10 square centimeters, big valve. And the posterior leaflet length was 25 millimeters, and the anterior like 30 to 35. The systolic flow reversal in the pulmonary veins indicated severe regurgitation, and there was also a mild tricuspid regurgitation. So the right head cath showed an RA of 50, PA of almost 50 millimeters of mercury, the wedge pressure was 30, and the cardiac output was 6 liters. No issues from the coronary vessels. So based on all that stuff, he didn't have coronary artery disease. He didn't went well with what we did. And the fact that he had these lungs made us think that probably this patient wouldn't survive and he wouldn't be weaned off the mechanical ventilation after an operation. So we thought that probably the most viable solution for him was the transcatheter edge-to-edge repair of the mitral valve. So we were planning initially for 2 devices at the A2, P2 segment. This is the guide sheath in the left atrium. We went for a Pascal Ace device. So this is with the opened device just underneath the valve to the lateral segment. We tried multiple times, simultaneously grasping. And this was the final result after the first device was released. And we had good grasping at the A2, P2 segment. we know that the lateral part was quite okay, but we had to put another device medial to the first one. And this is what we did. This is the positioning of the second device, medial, but not very close to the first one. Again, it was multiple attempts, simultaneously grasping. This is after we closed, but not yet released the second device. And this is what we had after we put the second device. And we tried to optimize the second device, mostly because we wanted to see if we had enough length of both the posterior and the anterior leaflet inside. So we did, so we didn't change or move it at all. And this was the final color assessment, which in our opinion was quite good, depending on what we had in the beginning. And this is after we released the second device. More views, and the final result with the 2 Pascal ACE devices. So this is the fluoroscopic image. I need to say that the devices are quite movable. They're moving a lot when we have DMR. They're more stable when we have ischemic mitral valve issues. Normalization of the PV flow after that. And this is how we remove the guide seat from the ELA. We had a very small left-to-right shunt. And the mean gradient was for like 5 millimeters, were very acceptable. And the planimetry of both the lateral and the medial orifice was calculated to 0.8. So the patient stayed in the ICU for 48 hours. He improved dramatically after that. He was discharged home 6 days after the procedure with 180 milligrams of furosemide, eplerenone plus amiloride, and steroids. He came 1 month later. He had lost 5 kilos. And he was like in 120 milligrams of furosemide and a tapering dose of steroids. We optimized his medical treatment just to have like lower blood pressure and heart rate. I'm sorry about the images, but I need to remind you that he was still 120 kilos. And we had like a mild to moderate I would say, residual regurgitation, but it was the best we could do. And the patient felt better, so that was our purpose from the beginning. 6 months later, 20 kilos in total less, good hemodynamics, less furosemide, no steroids, and the final echo views. The most important thing is that we didn't have the image is quite the same as we had immediately after the operation and 1 month later. So to conclude, I would say that MTR is the most important transcatheter treatment strategy of the mitral valve. We have technical device improvements, and because of that, the MTR is an effective option in selected patients. The MTR is currently recognized as an alternative to surgery in the latest American European guidelines, and in acute MR seems to be a safe and effective approach and to be present in all algorithms for the management of acute mitral regurgitation. Thank you for your attention.
Congratulations, Dr. Kourkoveli. It was a fantastic case. So in the future, we'll expect to have a M-tier call.
M-tier? I'm sorry?
M-tier call, as STEMI call.
I mean, I don't know if it's in the near future, but it's an option.
That's for the new generation.
Yeah, definitely.
And of course, it is a question because this gentleman was 61 years old.
Yes. Mm-hmm.
How long this procedure will last?
We don't know. It depends on him, to be honest, because if he remains
based on the experience already existed.
Mm-hmm. I think at some point he will have like a proper operation, but he couldn't be the case at this point. He was very unstable and he couldn't manage an operation. So if you ask me, I think probably in 5 to 10 years he will have like a proper operation in his mitral valve. But I mean, he's good now, feeling okay, and he went back to his daily activities. So yeah.
So this is an amazing case. Congratulations, and for the presentation as well. So did you have any any radiography and chest X-ray in the patient? Did you have any?
Afterwards.
Afterwards, the lungs. How are the lungs?
Yeah, so we still have infiltration. So he has fibrosis as well. But I mean, it's not. I mean, I didn't put it in the slides, but it's better. But it's not definitely as it probably. It's not a clear lungs, and probably he won't have clear lungs. We don't know what happened. We didn't have any viruses or something that might.
So and I noticed that you didn't change the diuretic, right?
No, we didn't.
Yeah.
We changed. I mean, we reduced like by one the Lasix, but I mean he stayed on 3.
Yeah, this is something that we discussed in detail in the morning, so we shouldn't, be. Maybe don't rush in order to change the diuretic dosages before. And so if there is an on-call, duty in our hospital in Mitral, I know the guy. So Dr. Leontiadis, so do you have any questions since you are going to be on call in these situations?
Congratulations on the...
Are you still ready?
Yeah, I'm ready.
For the ECMO, he's a constant... on call for ECMO and the mitral clip now, yes?
Yes,
especially in the early hours. Yeah.
Dr. Voudris, I'm always on call for his patients. So congratulations on the patient. Maybe this is like in CTO, this is an investment procedure. Now he lost weight, he's okay, he's better. Okay, this is not an optimal result, but maybe in 10 years or something, he could have a replacement of the valve, and so excellent result.
Okay, and Dr. Katsianos has a question, and maybe Dr. Poulimenos, if he's still around.
Yes, I was eager to speak. It was a brave decision. Congratulations and many thanks for being here, Dr. Iakovou. Congratulations to the team of Hygeia Hospital. Let's reflect on the case. You have a patient that might be septic. You have a patient with a flail valve that might be endocarditis there. It's not very possible because of the excellent imaging you had in the TE. But nevertheless, there is a slight possibility that is the cause of the problem, some endocarditis. Yet this patient would be lost if you didn't do what you did at the end of the day in a technically demanding operation, and with a very nice planning, as always, by your team. Pascal, I think it was very beneficial for this patient, and of course the results put many kudos on you and the team. I don't know how many of us would take the decision to operate in a possibly septic milieu, though, and but the result is that counts at the end of, is always that what counts at the end of the day. Congratulations.
Thank you. Just to mention, because I mentioned in the first slide, so the patient had all the cultures because he had like repeatedly blood cultures, sputum cultures, everything was negative. So he had a septic-like appearance, but we didn't have anything. So that's another thing that made us...
But yet, as you know better than me, there's a whole category of culture-negative endocarditis.
Yeah, definitely. Yeah, definitely.
So that it's not... you are not completely safe. You can never be completely safe when you have this clinical presentation. So congratulations.
Thank you.
And Dr. Katsianos, one final comment.
Thank you. Congratulations, Jota, for the great presentation. As Dr. Voudris and Dr. Poulimenos said, actually it was a rescue intervention. And in such cases, Dr. Poulimenos, we have the go from our infectiologist. A definite go before we proceed. And indeed, we have to say that we can use devices with a strong grasping. In this case, would also be possible to have a good outcome with the mitral clip, which shows the Pascal Ace due to the strength of the clasping. And I think we shouldn't consider a P10 in such cases because of the spacer, and then it doesn't have a lot of strength by clasping this device.
So do you think in this situation a more rigid device like the mitral clip would be a better proposition, or you think it would be more traumatic?
No, I think it would be a very good proposition, yeah.
Okay, good. So, Jota, thank you so much.
Thank you.